So we have two extremely important clinicians in the field of diabetology. We have a physician whose work in diabetes foot is well known in the city. And then we have a surgeon who I have worked and collaborated with a lot of my patients with diabetes foot. So we have Dr. Partho Sen as a surgeon, and Dr. Ghanshyam Goyal as basically a physician. So they are going to basically share what we should be doing in terms of recognizing the foot disease in patients with diabetes, and then the practical aspects of how do you take care of the diabetic foot per se, so that we can provide the best of healthcare for our patients. So I think it will start with a small talk. Dr. Ghanshyam Goyal wanted to speak, or did Dr. Partho Sen want to speak first? Okay.
Good afternoon. First of all, thanks to Havda Diabetic Study Society, Dr. Sanjay, Mridul and team for inviting me. Diabetic foot is one of the important aspects of diabetes care, and we all know the cost of treatment of diabetes foot is more than 5 most common cancers, and even the mortality of the diabetic foot is more than 5 most common cancers. So that is the, I can say, importance of diabetic foot, and how we have to approach, and prevention is the key in avoiding the amputations. So today I'm going to discuss a bit about the pathophysiology. I think everybody knows about it. Burden of diabetic foot, neuropathy evaluation, very simple, just simply monofilament test, vascular evaluation, ABI, then the classification of foot ulcers. Most commonly we use is, as you know, is the Wagner's classification, then University of Texas classification, then recently the Wi-Fi classification, and then offloading techniques, management principles if time permits, then the case discussions. So this is the neuropathy, we all know. It's the motor, sensory and autonomic, all 3 types of neuropathy. So there is a muscle wasting, foot weakness, postural deviation, and then the deformities, stress and shear pressures, and there is sensory neuropathy, stress on bones and joints, plantar pressure and callus formation, and there is a reduced sweating, dry skin, fissures and cracks ultimately lead to that. About the peripheral arterial disease, atherosclerosis narrows or block the arterial lumen, foot ischemia, ulcer, necrosis and gangrene. So it was a famous statement around more than a century back about the swords, no acid, no ulcer. It was in the relation with my gastroenterologist friends about the peptic ulcers. So no acid, no ulcer. But another statement come around 1.5 decade back about the no ulcer, no amputation by the gobbler. Then again, practically going to the 2 decades back, that position statement from IDF was that diabetic foot amputations are preventable, but still we are unable to reach at the target or goal of it. So how will approach these patients? So history and physical examination, as we all do in our day-to-day clinical practice, in our medical cases. Then lab measures, you doesn't require very advanced gadget, very simple, just very good clinical suspicion, eyes and a pair of hands, that is enough, suffice. Then how to manage? Mechanical control means offloading. Metabolic control, I think since morning everybody is listening about the metabolic control. And then microbiological control means antibiotics, mild, moderate, severe or non-limb threatening, life-threatening infection. You have to start, how you will start, and you have to take the deep tissue culture and start empirical antibiotics, and then after the culture reports you can de-escalate or you can escalate the therapy. Vascular control, if there is a peripheral arterial disease or PAD, then in that situation you have to take care of the vascular control. Wound control, the surgeon colleague Dr. Pratim is going to discuss regarding this very important aspect, and of course education control to avoid that it should not recur. Because in my patients, whenever a patient comes to me, I always say that your ulcer is healed, but it is in remission, because risk of having relapse is around more than 40% in first year, and by the end of 3 years it's 75%. So I never use the word that your ulcer is healed. Your ulcer is in remission, you have to take care of it. So that is educational control, you have to tell that. So In diabetic subject, always start your examination from foot to head. I use it that, or I call it the apadamastak in Sanskrit. You start examination, so you are not going to miss the foot problem or foot examination. That is very important. Famous legendary physician Paul Brent, I think everybody knows about him. Remove the patient's shoes and socks and examine the feet every time patient comes to you. Means no complaint, no policy has to be, no examination policy to be changed. And always whenever a diabetic comes, please examine his foot to avoid the amputation. More than 1 million amputations worldwide every year. Every 22nd a leg is lost to diabetes, and throughout the world up to 70% of all leg amputation happen to people with diabetes. What is the Indian scenario? As I was discussing along with Dr. Sain and others, very few organized diabetic foot screening programs, lack of podiatric services, multidisciplinary team approach is lacking, as we were discussing the same thing, and shoes and not really available, and socioeconomic factors, because it's a very important complication. And you see barefoot walking, walking on fire, Hawaii chappals use, and use of toy rings, or I can say foot ornaments. That is all this risk factor. This is a common presentation. These are the ulcers which you see, we see this the neuropathic ulcers, we can say on the plantar surface, high pressure areas, highly granulating, root, red colored. This is again neuropathic plantar surface heel ulcers, either doesn't heal or heal, then it's very difficult. A lot of callus around it, because to have a callus you need a lot of good blood supply to have it. So it's a neuropathic non-healing plantar surface ulcer, you can see it. So these are the different, all these we see day in out all this time. And this is the neuropathic ulcer again, and there's a lot of maggots inside the ulcer. So these are not sterile, so you have to remove it. Otherwise, sterile maggots are useful, and these are very good debriding agents. You all know about it. So about the bilateral ulcer, the very important aspect about the bilateral ulcers is it is very difficult to offload them. So you have to keep the activity level to the minimum in these patients, because otherwise, if you will not offload, these ulcers are not going to heal. And this patient was having these bilateral ulcers since more than 3 years. So we offloaded and we asked them to, and what minimum activity level will say, you have to walk less than 1,000 steps a day. There are studies also, so always remember that is there. Or the ischemic ulcers, I think they are the most important and difficult to treat. You need a lot of efforts, a teamwork, vascular surgeon, intervention radiologist, angioplasties, and cost lakhs and lakhs of rupees. That's why initially I mentioned it's more costlier than 5 most common cancers. Or the infected, you can see this leg, you cannot save this. To save the life, you have to go for a major amputation in these patients. So these are the generally most common presentation. During sunny and humid climate, you walk barefoot and landed with this sort of problem. So these are the common presentation. So who are at risk of diabetic foot ulceration, neuropathy, peripheral vascular disease, posterior foot ulceration, poor glycemic control, cigarette smoking, foot deformity, and amputations. So these are the International Working Group Diabetic Foot Guidelines. The 5 key elements that determine prevention of the diabetic foot problem. Identify the at-risk feet, regularly inspecting and examining the at-risk feet, and treating the risk factors for ulceration. So this is the crux of the whole of my presentation for the physicians who are present here, that International Working Group of Diabetic Foot says that the risk category, you have to categorize the fit by risk category 0, 1, 2, 3. So 0, no LOPS, means loss of protective sensation, no peripheral artery disease, no deformity, means annually patient should undergo a comprehensive foot examination once in a year, and that can be done by a journalist or by a specialist. Then if patient is having LOPS, means loss of protective sensation or polysensory motor polyneuropathy, in that situation, or plus minus deformity every 3 to 6 months, or PAD plus LOPS every 2 to 3 months. Ulcer or amputation history whenever a patient comes, or patient who is in Charcot's foot, whenever they come, you have to examine this. So first step to effective foot care is remove the shoes and socks and examine the foot. And even not the foot, you have to examine the foot wears also. What you need? One is the monofilament, another is a biothiometer, a 128 Hertz tuning fork, and it's a hammer. And by that you can diagnose that patient is having neuropathy or not. These simple tools. So there are two examinations. One is 60-second examination, another is 3 minutes examination. If you find something or something suggestive of it, then you can proceed for 3 minutes examination. 60-second examination, any previous diabetes related foot problems or foot pulses are palpable, is protective sensation intact, or is there any evidence of significant foot deformity. So you have to take the history like this and then physically examine like this. Is there a callus or callosities or ingrowing toenails, range of motion, all these. And if you find, yes, there is some problem, then proceed for 3 minutes examination. And what is it? What to ask, what to look, and what to teach. So what to ask? Patient's history. Is there prior history of angioplasty, stent or leg bypass, or is there any patients of neuropathy symptoms, or has to be regular podiatric care? And then second minute, what to look for? So dermatological examination, you can have a neurological examination, you can musculoskeletal and the vascular examination. So always try to put your fingers on the pedal pulses. It's a dorsal pedis or tibialis posterior. So by that you can go ahead. And what to teach? Foot care. Most important is never walk barefoot. Even you are indoors walking, because if you are in LOPS, loss of protective sensation, because you may hit and it may lead to the problem. And second is regarding education regarding the shoes, very important. Suggest yearly replacement of shoes more frequently if that exhibit high pressure, or if the insole is bottom out, you have to change every 3 months. So these are the things. So what is the aim? You have to identify it's a normal risk feet, normal feet at risk, present of significant neuropathy, significant ischemia or foot lesions. So how we'll take the history? As in we take in the general medical examination, we have to go for all these history points, and always remember that you have to check the footwear of the patient, because very important. Sometimes the footwears are responsible to cause the ulcers. One smart patient, who what he have done, we advised to have a the insole, and what he have done, he have stitches the insole with that, and that causes the ulcer on the seams have caused the ulcer. So always put that. So in infection, you have to look for the nails, you can look for this deformities, everything, you have to go for all these. And common are claustoids, callus, hematoids, bunions, all these you have to look for it. These are very important. And Charcot's, high index of suspicion, always I'll say, and we have got a huge series, around 145 patients of Charcot's in last 20 years we are having. And abscess, you can have a long and deep fissure on heel. These are very high risk patients. And always examine the interdigital spaces, because there is a high risk of interdigital mycosis, especially in this part of the country. Always when of the females especially goes to the washroom, they clean the feet. So at that time, this interdigital mycosis is very common, and that may cause a problem. So just by having a look on the ulcer, you can diagnose it's a neuropathic ulcer, or it's a ischemic ulcer or neuroischemic ulcer. So it's a valve, there's a lot of callus around the ulcer, you can see. Highs on the high pressure area. What are the high pressure area? Great toe, first, fifth, empty head and hilly area. So you see in the empty areas, and this the gangrene is always a wet or infected, it's not a dry gangrene. Neuroischemic foot, it's not pink, it's black, you can see. And it's not painful, it's very painful. It's very painful. It's just like ischemia, just like angina, it's very painful. Patients are unable to sleep. So that is there. Palpate the both pedal pulses, dorsal pedis and tibialis posterior. And you can see by simply putting your fingers on the pulses, you can diagnose. If it is absent, means peripheral vascular disease there. If it is feeble, there is a neuroischemia. And if it's bounding, means neuropathy, and normal means normal. So bounding, absent, or feeble, or it's normal palpable. So evaluate the neuropathy. There are a lot of modes we all know. So only thing which is very important in the monofilament test. Now, according to IDWGF, the International Working Group on Diabetes, the great toy, first empty head and fifth empty head. Out of those three, if a person is unable to feel at more than two places, patient is in LOPS. So very important, and remember it, 1/3 of the ulcers always occur at the area of great toy. That is really important, because on account of walking cycle, we all know. About the biothiometer, if it is more than 25 volts, patient is in high risk of diabetic foot ulcers is there, or high risk of having that. And about the foot temperature measurement, if it is difference is more than 2 degrees, always remember that there might be Charcot's. So you have to have a high index of suspicion, that is very important. Then about the peripheral arterial disease, not to miss performing a diagnostic ABI in any patient with symptoms of PAD. If it is less than 50 years, if patient is smoker, hypertension, hyperlipidemia, diabetes more than 10 years, you have to do a ankle brachial index once in a year. That is very important. About the TCPO2, it's a costly gadget, cost around 25 lakhs of rupees. So in that stream, but it's very important to know about it. Role of X-ray. Whenever a patient with diabetic foot ulcer come, please have a X-ray done. This is very important because you can exclude the osteomyelitis. In neuropathic foot, detect acute fractures, means Charcot's foot, and there might be calcification of the artery. You can see the calcification of the arteries, which is there, if it is there. And it's very common. If you, in our practice, what we find, out of every other patient is having calcification of the arteries, if the long-standing diabetes is there, so that is very much there. And these ulcers who are having calcification of arteries, we have got a strong correlation we find, if more than 2, I can say, if it is the ulcer having calcification of arteries, their healing is very much delayed than the normal patients. And this the non-compressible with adequate top pressure means ABI was more than 1.3. You see that this ankle brachial index is more than 1.3. The lower limb pressure is more than 300, but the toe brachial index is normal. So it was not having peripheral arterial disease. ABI you can see 0.49 and 0.69. You can see the peripheral vascular disease there in this patient. This is the normal ABI, and how to interpret 0.9 to 1.3, 0.7 to 0.89, less than 0.4 means severe or critical limb ischemia. When not to do ABI? When there is severe pain, or if you suspect that patient has DVT, in that situation you should not do that. About the toe pressure and brachial index, ABI abnormal TBI is less than 0.7. And about the diagnosis of PVD, non-invasive higher aspect resolution, and disadvantage is die if patient is creatinine or EGFR is less. In that situation, it is difficult to use that. In that situation, I think the MR angio is most important. In that situation where the EGFR is lower, creatinine high, I always advise to go for a MR angio instead of CT angio. About the diabetic foot infections, you can say grade 1, grade 2, grade 3, grade 4, no signs of infection, less than 2 centimeters, and is more than 2 centimeters, or it's a systemic inflammatory response system. And about this mild, moderate, or the severe diabetic foot infections, you can see about probe to bone test by looking into the diabetic foot osteomyelitis. This is you can see the diabetic foot osteomyelitis on the X-ray. And about the antibiotics, non-limb threatening or life threatening, you can say you can start with a amoxiclav plus a quinolones in the non-limb threatening, or I can say mild infections. Moderate, you can start with a piperacillin tazobactam plus linezolid, or with the life threatening or severe infection, start with the imipenem, cilastatin or ticoplanin, and take a deep tissue culture. According to culture sensitive report, you can escalate or de-escalate the therapy. And about the Wagner's classification, this is the most commonly used, of course. Grade 1 superficial ulcer, deep ulcer. When the ulcer is more than 3 millimeters deep, it's a deep ulcer, including bone, that is osteomyelitis. Grade 4 localized gangrene, grade 5 extensive gangrene. So this is the most common Y5 wound infection and foot ischemia classification. Then about the offloading, irremovable devices and removable devices. Total contact cast, that is the gold standard. But in our situation, I think this is one of the very good techniques, especially for foot and mid-foot ulcers. This is the indigenous technique of offloading. What we do, I'll just going to show you. Yes. So take a piece of foam, roll it, wrap in a piece of gauze, and stick with a micropore. So this can be practiced at the primary level. So this is a very good modality. We have presented our study in even ESD. It was a oral presentation in 2012, back to around 10 years back. So you can use it, and we are using it. It's a fantastic thing. So diabetics should treat their feet like do their face, and it should be teamwork. I'll say I'll treat foot, Sanjay will treat foot, or Dr. Sen will treat the foot. Nobody is going to treat foot. It's a team of the diabetic foot which is going to treat the feet. So dear friends, to summarize, periodic examination of foot is mandatory in all people with diabetic. Identification of early foot problems can prevent major events and cost. Identification of high risk foot is possible at primary care setting. Education of physician and patient is important. And I got just one more minute I can have. So I got three similar cases which are looks like, but see the management is totally different. This patient, 59-year-old, known type 2 diabetic, presenting with blackening of right great toe, you can see, for 3 months. Mode of illness, red rodent bite, 12 years diabetic. And you see, this was the X-ray which was done around 2 months back, but when he came to us on 21st of Feb, this was the X-ray. So it is, this is the osteomyelitis, and which is involving even the first empty head, and this is also involved. So it means you have to go for, these were the investigation of this patient, and you have to go for a ray amputation. I think the more light will be thrown by Dr. Sen. So as there is a osteomyelitis, so you have to go for a ray amputation in this patient. If you could have, by tempting, doing this, only the amputation of the great toe, you may be landed with the trouble, because there is a osteomyelitis. So you have to go for a ray amputation. We have put the patient on back, and this is the closure, wound closure. So you see, this is the results. And the similar sort of patient, this patient, 69-year-old female, came to us with the gangrene of left great toe. This, and only difference, patient was very severe pain. She was unable to sleep. And what we found, the ABI was unrecordable, and both the pulses were not palpable. So CT angio of lower limb arteries has been done, occlusion of mid SFA, superficial femoral artery. But you remember it, in diabetics, most commonly the artery which are involved is the below knee arteries, with the anterior tibial, posterior tibial, and peroneal artery, which are. But in this patient, there is an involvement of the mid SFA, and of course focal stenosis of ATA, PTA, and DPA. And so left SFA angioplasty and stenting has been done, and the angioplasty of the anterior tibial and posterior tibial arteries has been done, and the amputation has been done, and this is a follow-up after 6 months. So you see the difference, looks like cases, but the difference. The third case just came to 3-4 days back to us, 47 years male patient, right gate toe ulcer, plantar surface, non-healing since might be more than, I think, 6 months like that, and this was the X-ray, you see. There's the osteomyelitis of the X-ray, you see. So we discussed with the patient, we asked them to go for medical management or surgical management. Now in 4-foot diabetic foot osteomyelitis, we generally start with a combination of rifampicin, plus we have presented a paper in AAC last year about this role of rifampicin in combination with quinolones in management of diabetic foot osteomyelitis of the forefoot and midfoot. In that situation, you see, this was the osteomyelitis. We asked them either go for the amputation otherwise, or you can go for medical management. So patient agreed for medical management. So what we have done, we debrided, we have given a modified posterior slab, and we have made the walking window and insole, MCR insole has given, this is the posterior slab, and start with the rifampicin quinolone. So you see, all three cases looks alike, but the management is totally different. So thank you very much for giving me patient hearing. If anybody has any queries or questions, so we will answer. I think first Dr. Sen will do that, and after that we'll continue discussion. Thank you very much.
Thank you, Ghanshyam, for a lovely presentation. So largely, I think what he showed lots of pictures, but if your patient doesn't complain of any foot problems, please still see the feet. That is the most important take-home message. So, একশোটা পেশেন্ট ওপিডিতে দেখলাম, ডায়াবেটিসের এলো, চেয়ারে বসলো, সুগারটা দেখলাম, ব্লাড প্রেশার দেখলাম, চলে গেল, হ্যাঁ, এটা যাতে না করে. But I think we are burdened by lots of patients sometimes. So please look at patients' feet. And then you have looked at all the consequences, be it neuropathy, be it ischemia, and be it infections as on top of that. So, and Ghanshyam has showed you very nicely as to what needs to be done. So obviously, when we can't manage as a physician, we call the surgeon. So over to Partha Sen.
Thank you, everybody. Sanjay. Good afternoon, and welcome for this meeting. I'm the only fish out of water, I find, because I'm the only surgeon here. There is nobody to help me if I am in trouble. Oh, yes, Rajesh is there. Yes. Gynecologist. There was a famous word by Anupam Golash, but I can't tell this in public now. Anyway, I think Dr. Goel has explained everything in such a way. I have nothing much to add actually, to be honest with you. I think before I just go into it, we all know about the pathology of diabetic foot and why we have these ulcers, because already it's been discussed that is poor high glycemic control and neuropathic joints or neuropathic because of which patient gets pain, ulcers in the foot, and because of poor blood supply. But one thing we have to remember, because very interestingly, Dr. Goel's second patient who had improved with the stenting, angioplasty and stenting, because the diabetes is always associated with atherosclerosis. So very unusual to patient have a atherosclerosis, diabetes only without any atherosclerotic changes. So obviously, in the Western world, when I did my vascular surgery once upon a time, a long time ago, it was the teaching when the patient used to present with a diabetic foot or ulcerations, we used to tell them that death has started from the foot end of the body. So, and the more ulcers, more amputation, and obviously it is involving, and all of these patients end up having either a myocardial infarction because of the atherosclerotic or CVA or stroke. Anyway, now we have all discussed about this glycemic controls and everything, the pharmacological therapy of these foot ulcers, because that Sanjay has just mentioned about the patients, we need to control, see their blood pressure and everything. So we need to find out whether they have got a hypercholesterolemia or not, or improve their circulation. And the most important thing is to ask them to stop smoking, which is very common in our, everywhere, not only in our country, in everywhere. And along with that, normally an antiplatelet medication should be advised to them. But as a surgeon, I don't prescribe Clopilot because I leave it for the physician, which I dread badly. And my run is up to aspirin. That is what I prescribe them. And statins, if necessary, then I refer them to the physicians itself. Next, the question comes is about improving vascularization. Because as we need to know that the diabetic foot, the diabetes mainly affects medium and small sized blood vessels. Now I have got this here because since this is a very old disease and no pathophysiology or nothing has changed, so I am not going into any slides showing some gory pictures of fastidious feet and not. So if you remember, this is the aorta, these are the iliacs, then it turns out to be popliteal artery, then anterior tibial, posterior tibial, and peroneal, these three branches. And then obviously it goes into the feet. So we have to remember that the pure diabetes only affects only the small size arteries or the medium sized arteries here. But with atherosclerotic changes, you will always have an affection of the mid-sized arteries or larger arteries like iliacs and femorals, or even the profunda, or even patients sometimes have an abdominal aortic aneurysms or aortic stenosis. Aortic stenosis which give rise to the poor circulation to the distal limbs. So there lies the importance of investigations from the arteriopath point of view. Now how do we improve the circulation in the legs? Everybody we know that Dr. Goel has nicely mentioned about feeling all the pulses, checking for neurological deficits, ABPI, as we have mentioned, and the question of arterial Doppler. But unfortunately, I have to accept, but the quality of arterial Dopplers or venous Dopplers or arterial Dopplers in this particular case is not equal in all over the city. So sometimes we do get really a problem in interpreting those. So my trend, what I tend to follow, I feel the pulses, and if there is no posterior tibial or anterior tibial pulse, then I would ask them to go for a straight CT angio, or well, I would rather have an open angio, but patients avoid that because I used to always, I think Dr. Pandey will remember, I have sent him quite a few patients for a proper angiogram. But gradually, I think patients find it's easier to get it done because that needs an admission and everything to give a CT angio, and nowadays an MRI angio, MR angio. But the CT angio again, the question of angiogram doesn't, I think, is required in every single patient. One has to go to the history part of it when we should ask the questions about any pain in the calf, that is the claudication. So if the patient complains of claudication as well along with diabetes, then we have to interpret that the patient must have some kind of atherosclerotic involvement of the arteries as well. So in those cases, and if the patient has got a critical limb ischemia, then we should have an angiogram before going forward for the management. And from the diabetes point of view, we will find that because of the terminal disease, arterioles are affected mainly. For the angiogram may show a little stricture there, little stricture in the, say, in the femoral artery, but with very few collaterals. But the few collaterals means because the results of the angioplasty won't be as good as a normal one because it's a normal pathology or the physiology of the blood vessel, and if there is a blockage, all the collateral should open up. And once the collateral opens up, the claudication should go away on their own. But unfortunately, if there is a poor runoff, as we call it in the vascular surgery, then obviously the result of the vascular bypass or nowadays angioplasty is not that, results are not very good, unfortunately. This is all about improving vascularization and angio bypass, the oral bypass procedure. Next, the question comes for debridement. Dr. Goel has furnished very nicely on the slides about the debridements. I'm not going into detail, but only thing I have to mention that in diabetic foot management, the debridement, they will have to undergo a series of debridements, which is not acceptable by the patients all the time. They want to have one operation that will cure them completely for their lifetime. And not only that, and they fail to realize that diabetes is a systemic disease, and one amputation of a toe does not prevent him from having gangrene in the other toe, even with a general being under care of a good diabetes specialist also. So there we have a problem with the patients. And regarding the dressing point of view, we discussed about the offloading very nicely, and I've learned quite a few things from those slides myself. Then comes the wound dressing. Wound dressing you can use normally with betadine gauze people use, but I prefer not to use betadine because iodine is very toxic to the tissue itself. So you can use alginates or foam dressing or hydrocolloids or hydrogels or even silver impregnated dressings in cases of infective ulcers or not. I prefer personally hydrogels because in UK we used to use a gel, I think Sanjay might remember, it's called intrasite gel. This is available in India, but unfortunately not in Calcutta. I get it, we get it either in Ames, Delhi, they sell it from their counter, or you can get it in Amazon. Intrasite gel works miracles because it's a proteolytic and it does an auto debridement itself. And we discussed about vac dressing, which is good for an extensive wound. Vacuum dressing is very good. And finally, it comes to about maggot therapy. But our patients, they come with maggots. They don't need maggot therapy. And if you tell them about maggots, they are not going to stay with us anyway. They go to Howrah station and take the train to the south. And there are very interesting ointments being sold a few years ago, like platelet-derived growth factors, epidermal growth factors, and this and that. I still remember using something called Plurmin. I don't know whether it's still available or not. It's available? Okay, but the guy doesn't come to me. Maybe I don't give him enough business, Sanjay gives. The new trend is giving GCSF, granulocyte colony stimulating factor. I don't know whether that works or not, but whatever. And we discussed about the antibiotics, rightly so. And regarding antibiotics, yes, definitely we have to know that it's a mixed infection. So we have to have a gram-positive, gram-negative, as well as an anaerobic cover. And that's it really. And at the end, And the importance of a multidisciplinary approach, we always in a meeting, the topic starts here only and ends outside the campus. Only I can find Dr. Goel himself has created this havoc to start a multidisciplinary. I'm really surprised that he is carrying on for this such a long time in our city. And that's it. Thank you very much.
Thank you, Partho, for highlighting the surgical aspects and the practical aspects of diabetes foot. So together we had a lovely session this afternoon. And while physicians like a long list of antibiotics, I think the scalpel in some of our diabetic foot patients is best antibiotic really, because it basically gets rid of all the mucky infected wound which essentially needs to be removed and basically solves the problem for a lot of patients. So I'm very thankful to Dr. Sen, who has attended to many of my diabetic foot patients in the last 20 years of my practice. So with that, if anybody has any questions, yes, Dr. Bansali.
Thank you, Dr. Goel and Dr. Sen, for nicely presenting how to treat diabetic foot ulcer. My question is how to prevent it, because now recommendation is that give each and every diabetic statins. So if we give statin at the time of diagnosis, and keep LDL low below 70, then it will keep your coronary arteries patent, it will keep your cerebral artery patent, it will keep your peripheral arteries also patent. So diabetic foot ulcer is basically due to peripheral artery disease, neuropathy, and superadded with infection. So if you can take care of peripheral artery disease by giving high dose statins so that LDL is below 70 and throughout life, it will prevent peripheral artery disease to a large extent. Secondly, peripheral neuropathy is basically due to two reasons. One is ischemic neuropathy and metabolic. Metabolic will be taken care by blood glucose control, and ischemic, because peripheral nerves, they are getting blood supply from peripheral arteries. If you can keep them patent, then ischemic part of neuropathy you can prevent. And and once the patient develop peripheral artery disease, then we are having option of adding newer anticoagulant. Suppose AB index goes below 0.8 or below 0.7, then you can always add NOAX, that is rivaroxaban 2.5 milligram BD, because in this COMPASS trial, there were 28,000 patients, out of the 6,000 patients were of peripheral artery disease. And in them, by giving rivaroxaban, foot amputation rate was reduced by 50%. And no drug is as effective, reduction of foot amputation by 50%. So what are your views on prevention of diabetic foot ulcer by giving good amount of statin from beginning, and then regularly following these patients with the AB index, peripheral neuropathy checkup, and giving antiplatelet and NOAC as required, of course, lifestyle measures, stopping smoking, and in our country, stopping gutka, this nasal or oral, this tobacco will help along.
So last point first about the rivaroxaban. I was also a part of the RSDA guidelines which has been written for the peripheral vascular disease. As you have rightly mentioned, it's 2.5 milligram twice a day. You have to continue in the patients who are having peripheral arterial disease or peripheral vascular disease. That is one. And second, about the statin. We all know moderate intensity or high intensity, LDL less than 70, which were there. But important thing about the prevention of diabetic foot is you have to have a comprehensive foot examination, which I have shown you. It is according to the International Working Group on Diabetic Foot Guidelines, that if there is no LOPS, no PAD, no deformity, then once in a year, comprehensive foot examination, which includes monofilament test, or you can have a vibration perception threshold, that is that more than less than 25, or that is one, Or second, if patient is doing LOPS, then every 6 months. If patient is doing LOPS plus PAD every 3 months, or if a patient is having past history of amputation or Charcot's foot, or patient is having previous history of ulceration, you have to, whenever a patient comes, you have to check them. So that is the prevention. And second thing, as you have rightly mentioned, that, pardon? Primary prevention is, I say, no, these are also there, primary prevention. This part is this there. And about the statin, of course, we know, a lot of pleiotropic facts and all that. So about the, for peripheral artery disease, it is not there, but the only thing is about the peripheral artery, I have told you that that is a rivaroxaparin, but it is in established peripheral artery disease. Not in the patients who are not having peripheral artery disease, you will start it. No, it is there. And we have put these things in guidelines of RSDI, this 2023 guidelines, which we mentioned. About the primary prevention, there is no studies which have mentioned that use the statins for. Yes, what you have mentioned, the very important is topic smoking or nicotine in any form. That is going to help. Yes.
Does silostazole have any role?
No, I will just one more thing. Exactly what you have said, quality of life and everything. I would say that regular walking, and because these diabetics will have atherosclerotic changes in the arteries everywhere. So regular walking with a smartwatch, then doctor have any own money for the doctors. They will buy the smartwatch and walk. But never mind. For regular walking regularly will open up all the collaterals, and that will help them in preventing the ulceration, provided they walk in a proper ground and with proper well-fitting shoes. So walking is also very important.
Does silostazole has any role?
Sir, silastazole is a very good drug, but it is only useful in patients who are having intermittent claudication. That's all. Not for other things. So in that case, suppose patient walks 50 meters or 100 meters having claudication pain, in that situation it is going to help. Otherwise there is no.
Then how long to continue?
You have to continue till the symptoms persist or for even sometime life. But if even the limb ischemia increases, means suppose your ABI is around 0.5 or 0.6, patient not getting relief, then you have to revascularize. Either you go for a peripheral plasty, or you have to go for a pedal bypass, or sometimes a hybrid procedure is used.
You yourself use silostazole?
Pardon?
You yourself use?
Yes, I use. If I am using the silastazole, I use what Dr. Bhansali mentioned, high intensity statins, either 40 to 80 milligrams of the atorvastatin or 20 to 40 milligrams of rosuvastatin I am using, plus either, as Dr. Saina mentioned about the aspirin or clopidogrel, but if plus silastazole, if you use, the risk of bleeding is very high. So very cautious about that. That is very important.
Thank you.
Yes.
One more thing again I'll say about, because this is my personal experience, because in Howrah, in what we get, most of the patients, I'm talking about last 20 years experience. Now these drugs have come out very recently. So in the past, I used to do, when the patient used to come with claudication, I used to tell them you walk for 50 meters. Then once you get pain, you stop. But next day, you try to walk for 5 more meters. So and eventually, the claudication distance will improve even with aspirin only. Because as a surgeon, I hate clopidogrel, because it doesn't suit us at all. And so if they can walk through the pain, and I'm sure they will definitely benefit, from the claudication, and the claudication distance will improve every day.
Thank you. I think we are running late, so.
Absolutely. Absolutely. Absolutely.
Thank you for a wonderful session. A big hand to both our speakers, and felicitation.
And it's time to felicitate them. I would like to request Dr. GP sir and Dr. Sanjay Shah sir to please felicitate them.
Simultaneous felicitation.
Thank you, Speaker. Thank you, Chairperson.